and professor also of Environmental and Occupational Health. And also she has the honor of being our first in-person speaker since 2019. So this really, thank you actually for accepting to come in person. Apparently we really wanted you here and you were really ready to volunteer. Dr. Lichtveld studies environmental public health, focusing on environmentally induced disease, health disparities, environmental health policy, disaster preparedness and public health systems, and community resilience. Before joining Pittsburgh, she was chair of at Tulane University in environmental health sciences. And before that, she served for a while at the U.S. Centers for Disease Control and Prevention and at the Agency for Toxic Substances and Disease Registry, where she designed public health research tools and protocols to guide environmental health studies in communities located near hazardous waste sites. She's a member of the National Academy of Medicine and a member of the Consortium of Universities of Global Health. She's today to speak on the impact of exposure to chemical and non-chemical stressors on birth outcomes, neurodevelopment in a vulnerable, culturally diverse population. So please help me welcoming Dr. Lichtveld to the podium. Thank you so much.
Thank you, Dr. Baccarelli. And let's see if I can go to right here. To full screen. Is that good enough? Yes. So I feel very welcome here, not only because I'm a bit partial to environmental health, as you might imagine, but particularly since I have the honor to have in the audience my colleague Dean, and really the mentor for so many of us, Dr. Linda Fried. You are so lucky to have her as your Dean. Let me tell you that. Yes, yes, yes. What I'd like to do today is not only present, but it's to have a dialogue among established public health leaders and emerging public health leaders. And here's one of those, thank you, about issues, about exposures, about vulnerable populations, regardless of where they are, whether they're right here under our nose or whether they're in another country. Because as COVID has seen, and I'm very much forward to having some more conversation about climate, whether it's COVID or climate, it affects us all. And those are phenomena that don't recognize borders, correct? And so what is important to us locally is important globally. And so if you could first think about not seeing borders, but work with me through this environmental health threat and consider what our obligations are, both ethically and scientifically. So here are my original objectives, but I'm adding to this one more. I'm adding to this, and this is because of the conversations I had both with Dr. Baccarelli and particularly with Dean Fried, about what it takes and what our investment needs to be to work in a lower and middle income country to build a foundation of all of our research. And that foundation is not a wonderful team of scientists, we have those. That foundation is sustaining a public health infrastructure where we live, believe it or not, here in the US, and where we work all over the world. So I'd like to add that and do that more towards the end. So where is Suriname? When people look at me, they think I'm from Sumatra, or no, actually the Philippines is what most comes up, because I clearly have Asian features, but I'm actually half Dutch. So it's half Dutch and half Asian, about living in the Caribbean, having Dutch as my primary language, and a Caribbean cadence in my Dutch accent in the US. So you can see how confusing that is, right? But it is a country in the north of South America, right here, this little country there, with a really specific history that is very keen to what is happening here in New York City. There are not very many people who actually know that the British and the Dutch in 1667 exchanged Paramaribo for New York. That was their deal, and perhaps the British had a better deal, right? But that's what happened. And so you have the Peter Stuyvesant Tunnel and the Holland Tunnel and all of those Dutch derived names, but that's how it happened. So that was the exchange in 1667. So they exchanged Paramaribo for New York City. But in that country, where I come from, where I was born, it's about 500,000 people. In the last 10 years, something very tragically is happening. And it's happening because the country, as so many other lower and middle income countries, is mirroring what they see as the norm, whether it's the US or Western Europe. When I was a child, we really didn't have obesity. Then the last 10 years that I'm going back, we have right next to the hotel, Kentucky Fried Chicken, Pizza Hut, McDonald's, and et cetera, et cetera. And so they're mirroring what they think is good for them, and clearly it's not. And so when I practiced medicine in the interior, and I you know that, I decided that that's what my future would be. I never envisioned my life without a stethoscope around my neck. How wrong was I? Yes, I use my clinical degree, but it is public health where we make the biggest difference. When we did that back in the 70s, there weren't any of these problems. There wasn't gold mining, which I will talk about. Suriname now has on its shore, and it is coming, and that's why addressing climate change is so important. One of the richest oil discoveries just happened, and already we're seeing the change. So I'll talk a bit about agricultural pesticides and the use of that. And I ask you, when I share my research, I'm asking you those ethical questions. And so you'll see those ethical questions, those public health questions coming up. The other emphasis that I will place is the role of culture. We have such a rich culture in our cultures in our country, and yet my sense is that we're not maximizing what we have and what we learn. And so this afternoon for lunch, I'm going to eat fried plantains. So the study involved three main study areas. The capital, as number one, Paramaribo, which is actually an indigenous name. The two areas to the west of the country near Guyana, and that's the agriculture-rich area of Nikeri. And then several sites in the interior. And so last week, somebody asked me how many languages I speak, and I said 6, and they automatically thought 6 Roman languages. So I speak several Roman languages, but I also speak the languages of the indigenous and the descendants of runaway slaves, the Maroons, because otherwise I couldn't practice. And so the commitment to the patient, it's not the patient's role to make sure they understand your language. It is our responsibility to make sure we understand the language. And so pesticide exposures, when I teach, I ask my students, what are the 10 things that are wrong here? And so some of you might be students, and so maybe we can have that conversation later, but you could see a lot of what is wrong there, right? No personal protective equipment, spraying right where people are bathing, and here almost professional spraying with something that looks like personal protective equipment. I'm also fascinated by when we go to airports now, or when we see people on the street, the many variations on a mask that we're currently using and pretending that we're protecting each other, or protecting ourselves. And so it is in this area that our research, one of our areas for research. So as I present, I tell you stories because I know that you will remember stories. Tanya, this vegetable to the left, is the vegetable with some of the highest levels of iron. And it is the vegetable that is given to kids, to me as well, at 4 months when the child is first beginning to eat. It is also that vegetable where we found pesticides that were banned worldwide since the 1970s, including endosulfan. So how did the pesticides get there? If they were banned since 1970, is there a special stash that somebody has? Are those pesticides coming in the country illegally? How did they end up there if they're globally banned? This is where public health leaders come into play. This is where we are responsible for developing policies that prevent things like that. When I go back, yes, I still eat some of that and then hope that my immune system will take care of whatever I have in my system for that one time. But if you give it to a baby, to a 4-month-old, every single day as its first feeding of solid food, think about what's happening in terms of the load of exposure. The other item I want to point out is these long beans, these yard long beans, another favorite vegetable, another vegetable that's contaminated with pesticides. And so one of my students, who's now an assistant professor, we published together on what we actually found. In that area, remember that area to the west, we collected about 200 or so urine specimens to look at some metabolites of the pesticides that are most often used. And so what's happening there is a tradition that the father or the grandfather has put in place that a bit more is always better for when you spray. And if you mix it, it's even better. So pesticides and herbicides and all of those combined vegetables make that you have more yield. And so the educational piece is missing, and also the policy is missing. So it's not only policy development, but it's policy implementation and policy enforcement, right? I mean, that's what we know in general, whether it's in environmental health or otherwise. The data are not necessarily there in country. Our responsibility is to provide those data so that we can inform policy development. I won't bother you with all those chemical names there. But see, here's what we found. 2,4-D, and those in environmental health know exactly what 2,4-D is. As you can see, if we look at the 3 study site, the purple is the site where the agricultural area is, where we collected the urines from the women, and we did this in coordination with, in collaboration with my old lab at CDC, when I was at CDC. So you can see clearly, we're finding urinary metabolites in women who live in this rich agricultural area. When you go to the market, and I do that, I take students with me every July. When you go to the market there, the market that you just saw, the people who live there tell you that the vegetables that have the little holes of the insect in it are bad, so don't buy those. Those are actually those are good because they haven't been sprayed with pesticides, but this is where I think the gap in literacy is as well. What is fortunate is that some of the essential elements are actually in nuts and other products that people eat. Pay attention to this picture. It's kind of like a pizza of cassava. The cassava is fine, but it is the plate that they're working on, that pizza pan, that is contaminated with lead. And so the choice is here, do you tell them not to eat cassava bread? You can't do that. That's primarily their only source of starch. Do you buy them? And we tried some of that. to buy them a real stove. It didn't work because culture tells them that that's the best way you make that cassava bread. You will recognize this fish, right? That is that's the piranha, yes. And so the women who live near the gold mining area love piranhas, and I love piranhas. I make a really good piranha soup a long time ago, not now. But it turns out that piranha, of course, is a bottom feeder and has one of the highest levels of mercury. So here you see, this is a dietary survey which we followed up with real measurements, both in the fish as well as in the women. You'll see that in a minute. But if you look at the Aymara is another, the Aymara is another very well-loved fish, also high in mercury. So the riverine fish are the ones that are very contaminated. The sea fish, not so much. This gives you a sense of what they like a lot. This is you could see the Wilcoxon rank sum test of the contaminants that we found in the specific fish. So I'll take you back to the country, and I want you to see in this picture, that's primary rainforest. Yes, everybody with me? This and this happened in a span of about 90 minutes. The loss of primary rainforest. I can tell you that because we walked in with the students, and by the time you walk back, this was the result. This will never come back. And it's all done because of what they call small-scale gold mining. This, of course, is not small scale, right? And it's not stopped by the government because there's a ban on mercury. It comes in via Brazil, it comes in via Guyana, and there is no ban or no regulation in responsible mining because some of these small-scale gold miners are actually earned or are owed, and the land is part of the assets of political leaders. So you can't fix the problem this way, at least not through politics. So the best thing I can do is to provide data so that we can develop evidence-based policies. So here is a little bit more. That's the yucca, obviously. This is that perfectly beautiful yucca bread. There's also gaming going on. And we find a lot of lead, high levels of lead in some of the game. And of course, there's now that they no longer use bow and arrow, they use guns and lead pellets. This is interesting. And I don't know, some of you, of course, so many of you do global health research. This is Pimba, and Pimba's clay. And the clay is sold on the markets, and the clay is sold to the villages. And it's consumed particularly during pregnancy because it's rich in nutrients, but it's also rich, of course, in all the metals that have been deposited. And so you could see there is a complex set of exposure sources that ultimately then result in those high levels. We are fortunate, and I'll come back to selenium in a minute. We're fortunate that these other things are going on in terms of exposure to essential elements that should be helpful. So we have, and I was sharing with Andrea, we have about 15,000 biospecimens of this environmental cohort study. This 1,200 moms and babies' diet. But we've analyzed just for now the 400. We're hoping to get another 1,000 out of the HERE program. And this is what we found. So if we look at blood lead levels, blood mercury levels, and blood selenium levels, you see that they almost are identical. And so you could say this is a double whammy, so to speak, right? We have and blood and mercury and lead. But this, we don't know yet how this is countering what we're seeing. Because if you only looked at from the diet assessment, we know that the women eat fish sometimes 3 times a day, every day, during the week. And so we're still not seeing, if you can anticipate the levels, even at they're higher than you would normally see them. And you wonder whether selenium gives somewhat of a protective effect. And so that's what we're looking at. So this gives you some initial, these are all median levels of blood elements. And so you can see the clear difference, right? This was the capital, this was the agricultural area, and this is the interior. And so you clearly see where the elevated levels are. This is mercury, and again, you see that. So it's our problem is in the interior for the most part. But this is selenium. Also very high in interior women based on their diet. So we're wondering that the selenium is maybe masking some of the mercury exposure that we're seeing. This is manganese, and you could see manganese is a component of several pesticides, and you could see that indeed lining up with the exposure there. Same thing goes for tin. And so we're seeing elevated levels of mercury, lead, and selenium in the interior women. We're seeing median concentrations of manganese and tin higher in women who live in the agricultural areas. And we're also seeing median higher levels of lead. So if we look at some of the socio-demographic variables, again, the confirmation of the interior, but also we see it in somewhat older women, so the longer exposure, ethnicity, the indigenous and the maroons, as we shared before, and women who tend to have lower education. So it's not different than we see in many other populations. If you look at lead, again, women in the interior. So we see that this correlation between lead and selenium, mercury and selenium, and then lead and mercury in concentrations in blood that we talked about, the survey that we did. But this is, I thought we should note, literacy is really, really important, and is, again, another ethical obligation, as far as I'm concerned, to us as public health leaders. None of the women thought they were exposed. None. So then we also looked at the exposures and adverse birth outcomes. So you see this traditional definition, what those are, a preterm birth, low birth weight, and low Apgar score. And this is what we're finding. So for the most part, not a lot of preterm birth, but more in the area of low birth weight, depending on how we see that with relationship to the exposures. This is a better idea how you see that with the exposures here. And lead is primarily the leading cause there, the leading association. If we look at, again, with lead and the variables, and we look at the confidence interval, you see the same thing. Now, if we developed a predictive model and we looked at birth weight, and you could see with blood lead levels linked with maternal age and intake and with where people live. So really the geographic area where people live determined, unfortunately, their health, as it is with so many of our communities here as well. So then from moms, we go to kids, and this is very preliminary. We have about almost 1,000 kids now in the cohort, and these are the very first results of the Bailey test. This is looking at cognitive development particularly. For the first time, and this is one of the areas that I want to point out, and actually the challenges you have to do global health research, and you have leaders like Dr. Elzada, so thank you for being here. We had to validate any of the tools, any of the assessments that we've used for this particular community. So, and we talked about, Bob and I talked about what it takes to do all of this in a 5-year span. You can't do this in a 5-year span. It takes time to identify the research, to set it up, and then validate anything that is not necessarily internationally validated. So we're doing a lot of groundwork for other studies to be able to happen. But we have some results, some interesting results. So this is good reliability here, but you could see in terms of exposures and the impact on both fine motor, receptive, and expressive. These are all some very preliminary data that actually you're seeing for the first time. And you could see that with depression, you could see with lead, the combination of lead and both the impact on the receptive and expressive development. We now, the children are now 3.5 years old. And so we've looked at it again in a small subsample at autism spectrum disorder using MCHAT. And some very, very early results are showing that we might be currently in a lower risk area, but we're concerned about what we're seeing in the moderate risk area, and just in 100 and some kids. So when we have done all the 1,000 kids, I think we'll have a better picture. So it's selective. We see blood mercury levels greater than 3.5 associated with elevated risk. Lead associated was not associated with elevated risk. And so we're not, I don't think these are results that are publishable right now because the cohort is too small. So from chemical stressors now, I'll transition to non-chemical stressors, and I need to pay attention to the time because I do want us to have a chat. So 1143 was our denominator here. And we looked at prenatal depression using Edinburgh. And we used the Cohen perceived stress scale as well. So here are some of the initial results. This surprised me. And I was born in the country, I worked in the country, I've trained in the country, but this surprises me to have this high level of high perceived stress. I had not expected to see that high. And in fact, in a month, one of the Surinamese students is graduating with a PhD, this research. When you look at the EPDS scores again, some worries.
How does this compare to other countries? I don't have a basis for comparison. So are these numbers similar to other countries that you expect? Are they higher or average?
This research has not been specifically done in the Caribbean yet. We see some of this in the, thank you for asking, we do some of this in the India population. And so we see more of that in that ethnicity group. And this is not part of my presentation right now, but in that group, and that is true for Suriname, Guyana, and Trinidad and Tobago, where we have large percentages of Indian populations, that we see pesticide-induced suicide in very young women. And so while I should have expected that stress level to be increased, I didn't expect the magnitude to be this high. And actually what worked most effectively, psychologists didn't work, psychiatrists didn't work, because it's a cultural issue. That's where I started. Hotlines or warm lines didn't work. And ultimately what worked is I went back to my old CDC hat and we trained community health workers and embedded them. And those were heads of principals of schools, heads of community organizations, and that is working. And so there's a whole area of research that I've done before, but not included in this presentation. And they are now part of our research team. So this gives you an idea of perceived stress. Again, the story is the same, and this is the complexity of why, or conversation about why is environmental health not the most popular or the sexiest thing on earth, right, in public health. It's because we don't think this way. We think very narrowly, but if you look at this approach, it is a very complex set of factors, to your point, that come together. So one of my ethical responsibilities is to tell it as it is when I go to the country, and then I had to sharpen my Dutch again when I do so. But otherwise, researchers in the country are afraid to speak up, are afraid to provide the data. I go in and I leave because I am a US citizen and I'm here. So I find it ethically responsible to share the data first with the community, then with the government, before we publish. And so this is what I do every time I go. So overall, disparities are in this population. Of course, the whole country is disparate, whether it's health or otherwise, but disparities really are by geographic region. And you could see that the 3 regions as we discussed. We saw at first associations with adverse health outcomes, both in preterm birth and low Apgar score related to lead exposure. We saw high perceived stress related to low Apgar score and low birth weight. We saw maternal low education level related to lower cognitive and fine motor and receptive language in the kids, so using Bailey. And we saw high exposures to lead potentially related to elevated risk for autism spectrum disorder. And then, of course, we saw the non-chemicals, the stress related to adverse birth outcomes. So what to do in the future? We must identify the sources of exposure of lead. We suspect it's that pizza cooking pan, but there are other sources. Traditionally, NIEHS does not fund that. They don't necessarily fund the environmental component of it. We'll continue to do health outcome assessments. We'll continue to do elemental analysis, but also metabolomics. So that's our next area. We now have the raw data from here and beginning to look at that. So I want to kind of end with where we're going, and I very much look forward to talk more and collaborate more with the school here on climate and health, because it is disproportionately this area, this region of our world is more impacted by the changes in climate, and yet does not have any of the infrastructure to address those. We convened a focus on the Caribbean and climate change and health, small island nations. And here are the 4 areas that the conference together identified. There's a lack of air monitoring and population-based studies. So clearly there, when I shared that Saharan dust impacts childhood asthma in Puerto Rico, people look at me like, did I lose my mind? But we can measure it, we know. A transdisciplinary approach to data science. There's limited to virtually no translation into frontline action. And so if something is happening, it's happening, you know, in the walls of the university rather than being on the front line. And there is an absolute lack of workforce. And that's true all over the world, but particularly in the Caribbean. So if I would put my non-public health on, and I would look at, and I would become somebody that does weather, and I look at how potentially changes can happen in depositing mercury and therefore higher mercury exposure. So there could be directions in wind, and that is happening there. It's hotter, it's drier, and it's flooding. All of those are happening at the same time in the country. So regardless of what change is happening, ultimately we have more mercury released. And so the interaction and the intersection of the influence of climate on environmental exposures is undeniable, undeniable. And so I'll go back to my former public health days at CDC, my public health practice days, where we know there is a direct relationship and bidirectional among science, policy, and practice. We are not doing enough of this. Policies are still created at the back of an envelope, so to speak. And we're definitely not doing more of the application. We often don't pay attention to what's happening on the front line so that it can inform what we do research-wise. And research must lead to risk reduction. Otherwise, to me, research has no purpose. And so when we look at sustainable development and how to integrate environmental health into that, it's looking at what's the quality of of the environment in the poorest countries. And the poorest countries don't necessarily mean only outside of the US. There are many, many poor areas. I've moved to Pennsylvania, and Western Pennsylvania and rural West Virginia might as well be in a developing country, in a lower and middle income country. So we don't have to look very far to find poor communities who are at cumulative risk for so many of these. And ultimately, it brings us back to policies, practices, and technologies to promote sustainability. Here are some other relevant citations, but before I end and thank my colleagues, I'd like to focus on a conversation that Dean Fried and I started this morning. And that's the floor of the public health house. So if you imagine the house this way, most of the funding goes to the roof of the house. That's all where our programs are, whether it's diabetes or hypertension or whatever outcome we fund. There's a little bit of funding that goes to state health departments and local health departments on surveillance and laboratory networks. There is virtually no funding, like 0.01% of, I think, the DoD budget as a whole, but maybe 0.0001% to the floor of the house. Like, I made a mess on your floor, but imagine this was not a good floor, and you didn't fund the people who work. Both qualitatively and quantitatively, you didn't fund the workforce, and you didn't fund the organizational capacity. Imagine you couldn't connect all these floors in the School of Public Health. How would you function? Or that we have in many schools of public health, where one department doesn't work with the other department because, God forbid, you get out of your silo. And then the third piece is, what do we do with all those data? How do we manage those data? And so it is our responsibility as public health leaders to advocate for the floor of the house. It's a longer way to get funds It's an easier way to get funds for the top of the house, for the roof of the house. It's not so much on the non-sexy part of what we stand for and what we do. And so it is our responsibility, and I'll end with that, and I'll entertain questions and dialogue, to make that non-sexy part of our discipline the sexiest. So thank you. Yes.
Dr. Lichtveld, thank you. That was really fabulous. I want to ask a question about the last comments that you made about the need to tighten the link between science and policy. And although I also agree about the practice side. Well, given the weaknesses of policy leaders over the last 30 years on really drawing out those links, and the need, I think, for more clarity and push from the scientists themselves, is there an organizing group among schools of public health that exists at the environmental level to advocate for the policy, where the science is ready for and can direct policy direction? And is there a unified group that does that? I'm saying that as someone who's not an environmental scientist, but I completely agree with you about the need to strengthen those.
Yeah, I hate to say no, but it is no, and I'll tell you why. We are in environmental health way too siloed. I look at my own school of public health, and perhaps you do a much better job, and you do a much better job here, but how does infectious disease lead to environmental health? How does genetics lead to environmental health? How does the bench lead to environmental justice? Those are all elements of environmental health, and we're not necessarily a cohesive enough group to be that advocate. The second thing that we're not pushing is we make public health issues partisan. And the last time I checked, when you die, you just die. You're not dying as an X or a Y, right? Not gender, I mean. So we don't do that. And thirdly, we expect that our science, because we know it all, should be naturally and automatically understood to those in politics who often don't have that kind of background. And so we need to come together in a cohesive group, one. Two, we need to get off our high horse and be able to translate. I work with students on communication, and I tell them, I want you to deliver any message that I have at the 8th grade level, at the 3rd grade level, I'm sorry, 8 years. Imagine you have a little one of 8 years at the 3rd grade level. And you could use ways like 3 messages, 9 words, 27 words together, and tell me what the issue is. Tell me what the problem is, that you acknowledge it. Tell me what you're going to do, and tell me what they can do for us. So we don't translate well to politics, and we also don't approach things as strategic enough. The way, and so in my almost 2 decades at CDC, we couldn't lobby, right? But we could educate. I educated the, out of the staffers, not the policymakers themselves. We now, collectively as deans and as leaders in environmental health, we now can lobby in a way or educate in a way and find out where it hurts most, where it's relevant most. When I worked with policymakers on disease X, it was because there was disease X in their family, or they lost a child, or they lost a family member. Unfortunately, that's what ticks. And so we have work to do, the politicians have work to do, but in our control is becoming more cohesive and being able to translate that very complex science into normal speak at the 3rd grade level. Please.
So, did you see any evidence of inflammation in the cases you had with autism? Do you look for cytokine activation or anything similar?
We are going to do that, but we did see, thank you for asking that question, and that's a publication I didn't have in here, but we did see impact on child development with reports. Now, these are reports that did the physician tell you kind of thing of respiratory infections. We did see that. And so in our next phase, we submitted R1 a couple of weeks ago that will look at inflammation as well, and looking at cytokines among other markers. And we're also going to do that in another R1 that I'm submitting to NIA, in a multi-generational one to look at exposures and EDRD. So we're definitely going to look at.
Ezra was on the line. I think he probably still is. So we recently completed a large study of mid-gestation and cord blood analyses in ASDs, and found that there was a dramatic association between inflammation and specific cytokines located in mid-gestation as well as cord blood. So that's something that you might want to look at.
I'd love to do that. I'd love to collaborate.
I'm not suggesting I want to collaborate because I don't do it anymore, but it's something you can get from commercially.
No, I appreciate that.
And the other thing was, in terms of the ASDs, was there any association with sex?
Yes. Yes.
Of male?
Yes, correct. Yes, we did. And I didn't present that, but yes, you're right.
And then the last question on that had to do with IQ, because if mercury is a factor, I'm wondering if you saw any differences with IQ.
So we decided not in the first round to look at IQ because of the differences in language and the differences in education. For example, when we did the Bailey, we had to replace, what was it? Some animals and a car in the interior for a boat and a tiger. And so we had to make that, we have to culturally adapt that. So we haven't looked at IQ per se yet, but as the kids get older, that's what we'll plan to do.
And the last thing, which was really suggested that might be helpful in reducing risk, is mercury. I know you said it was really in the bottom tiers, but in addition, concentrates the higher you go up the food chain.
Correct.
So if you substituted tilapia, right, tilapia and so forth, you would have less accumulation of mercury, and that might be safer for the people who fish them. I have to go, but I just want to say, if you want, I can give this to Andrea. I can tell you where you can get your samples run very cheaply.
I'd love to know that because of it's 15,000 biospecimens.
Sure.
We tried, the last thing is we tried, and thank you very much. We tried to supplement or replace the fish. The women didn't want to do that because they like tilapia and the other ones. Thank you.
This is Ezra. I thought your talk was wonderful, and it sort of encapsulates, everything that I believe we should be doing in public health and global health. So thank you. It's really inspiring. I have a question. It's a little bit off what you were talking about, but I think it's related. The Caribbean region, really, this applies in many parts of the world, but especially in the Caribbean. It was so transformed by colonialism and also slavery, and the history of the Caribbean is so, it is so much a legacy. The present is so much a legacy of that. And I'm wondering if that, how do you think about that? Is it something that you think should be like central to the conversation or should not be in the conversation? I'm just curious as to how you you know, what your perspective is.
Yeah, it's very much in the conversation. So much so, it's the reason why I couldn't go back. And so this is not the time to tell my personal story, but we were a colony of the Netherlands after the British and the Spanish. Columbus, of course, was there as well in 1492. And then we became independent, but really not independent enough to prevent a military coup. And that has devastated. And so while we became independent, nothing was left behind in terms of research infrastructure or public health infrastructure. And so the burden of colonialism is alive in many of the islands and many of the countries today. And while there was developmental help from the Netherlands, and that stopped, of course, after the military coup, it's coming back, but the resistance to that and the old traditions are just, you can't take away. And it very much is embedded in the infrastructure of the country, in the thinking of the people, that what's outside the country is always better.
Thanks.
Thank you. And Farouk had a question?
Yes, hi. It's an excellent presentation, and it's really I see some of the similar problems that we see in Bangladesh, and for including the colonial past of the country. But what really I was just interesting is that you are replacing some of the items like cars and planes, and we're doing the same thing, like apples and oranges by mangoes and bananas.
Yes, very much.
Right.
Because when we do the dietary survey, what we actually had to do, this is interesting. Thank you for asking the question. We couldn't say it's how many grams of fish do you eat. And so what we did is we took pictures of the size, and we said, does it fit in your hand, in the palm of your hand, or how big is it? And if we needed to know how much rice do you eat? So instead of saying, do you eat 20 grams of rice, 120 grams of rice, we actually used literally spoons. And he said, how many of these spoons do you use? So really adopted in somewhat of a unique way and practical way and a respectful way, the cultural traditions, but yet keep the scientific rigor. And that's not easy. It takes time. And, we all need to educate NIH what it takes to do research in the developing countries, because it's not easy.
Right. This is another similarity when we were doing our food frequency. In fact, we're carrying jars and weighing.
Yeah.
But my question is a little different than, is that because I just came from Bangladesh and we're doing a training on environmental health and neurocognitive development in young researchers. So there is an outcry, and in fact, everybody was saying that autism is almost a level of epidemic in the population. I don't know why. Maybe it's true. Maybe it's more of like measurements and assessment issues, and people are becoming more aware. But you showed one slide only on lead. What do you think of other metals? For example, manganese, which has a strong effect on some of the brain organs, for example, basal ganglia and other parts of the brain. So
yeah, we are so in the next group of 1,000 metals, we are going to look as well to the other metals, and we are going to analyze more of the urines. And so we have 1,000 more urines, and manganese is where, particularly in the agricultural rich areas, where we see that. So that's those are so many of our next steps, one of our many next steps. I need to respect time, it's after 1, and so I need to turn that back over.
Thank you.
Thank you so much for the amazing presentation and an example of how environmental health can impact public health and beyond. If there is anything beyond public health, I mean. Thank you so much to everyone who joined us in person, and thank you to all online. And I will ask for a final round of applause. Thank you so much.